now go on to our guest speaker's keynote address. He is none other than Professor Mohamad SHAFIK, who is a professor of ophthalmology from University of Alexandria, Egypt. And he's going to talk to us about customized surgery for refractive and therapeutic corrections. On to you. Sorry for keeping you waiting, doctor.
No, don't worry. Thank you very much, Dr. Chitra Ramamurthy, for the introduction. Thank you for the esteemed panel. I'm really glad to be with you today. Yes. And I'm going to address a line time analysis of my practice during the past 30 years. I'm practicing refractive surgery maybe since 1991, when the time was a radial keratotomy. And now I'm going to shift my customization to another level. But let me start with the customization. This is my financial disclosure. And the story, why do we really need a custom-made refractive surgery? Actually, because of three major causes that we are going to address in every patient. Number one size doesn't fit all. And number two, targeting the supervision. And of course, number three is addressing the irregular cornea. And 25 years ago, when we got introduced to the science of aberrometer, we got to understand that one size doesn't fit all. These are three patients for the same refractive error. Nevertheless, they are totally optically different. This was the classical teaching that we got to know from the perfectionizing the aberrometry. And because of that, if, for example, you have a reading from your aberrometer like -188 cylinder, and this happens every day, while the patient is a manifest refraction of only -1.5 cylinder, you know that the rest of the cylinder is in the higher order aberration. And we know by a mathematical equation, which is a little bit complicated, that the astigmatism goes higher with a higher order aberration and the pupil size. So one size doesn't fit all. And if you really wanted to have a happy patient, you have to customize his refractive surgery. More than 12 years ago, we published the first publication on the use of the customized refractive surgery with front guided type on the virgin corneas, and the wow effect was there. 26% of the patients were seeing 20/16 or better. So if you want to advise or to promise your patient a kind of supervision and extend the vision beyond the human ability that we know, you should go for a sort of customization. We knew since back then from this nice work of Shalita that if again you want to have a patient with a hassle-free halos, glare, night vision problems, and the secondary imaging and ghosting, you have to customize the vision, or you have to customize the refractive error to have a happy patient and to avoid all this hassle and fuss. And thirdly, the most important thing that we're going to address now is a kind of irregular cornea, which is a challenge that we meet every day as a refractive surgeon. You might say that irregular corneas are very rare. No, oppositely the contrary, because every mixed astigmatism, every hyperopia, every high astigmatism is a kind of irregular cornea. Every previously touched cornea with a previous LASIK or even SMILE or PRK is an irregular cornea. Every subtle opacity on the cornea is an irregular cornea. So if you have a refractive practice, you might have half of your patients with a kind of irregular cornea that you have to customize the ablation profile with it. We began with the topo-guided ablation profile, and Dr. Chitra Ramamurthy addressed nicely every single profile that we had, and I started the topo-guided ablation profile and then followed by many other platforms, and that was a kind of a customized one in the year 2004. And of course, it ended with the nice and well-known Athens protocol addressed by our dear colleague John Kanalopoulos that changed the world back then in treating the irregular cornea, and on top of which is the keratoconus. And for me, the topo-guided ablation profile is so harsh. It's like killing an ant with a sledgehammer. While you wanted to flatten the whole cornea and regularize the whole cornea, you might have a nice pencil. And this was addressed by my dear colleague Gustavo Tamayo when he said back then, that it is a kind of a kind of crude cause-effect relationship. 2007, the nice tool of the corneal wavefront invented by Schwinn again was addressing this kind of ablation profile by simply deducting the wavefront from the normal placido disc, and I used this to have a significant treatment of the significant decentration of hyperopic patients, some kinds of very hard irregular corneas. Yet, for me, if you treat only the anterior surface of the cornea, you are uncovering the posterior surface of the cornea, and this might have a bigger problem and might unreveal the irregular surface. For me, a wavefront guided ablation is a proper addressing of this, and of course the introduction of the higher definition aberrometers in the year 2012 or 2012 was really the treatment of a choice, and I addressed this by the first publication of using the higher definition aberrometer to address the irregular cornea, with nice examples like those with an irregular cornea, where you create an irregular ablation profile. You go and do it by removing the epithelium. A wavefront guided ablation was the perfect choice to regularize the cornea and to provide the patients with the very good vision. And these were the corneal cross-linking patients, and I changed it totally. The paradigm, it was a paradigm shift. You have a nice point spread function at the end, and it was my publication in 2016 by shifting the wavefront guided ablation and treating the keratoconus to do it after 1 year of cross-linking and to address properly the irregular cornea. You have hundreds of bilateral keratoconic patients. When you create a nice shape with a wavefront guided ablation profile, and you target more or less the emmetropia for those patients. Finally, the legacy of the refractive surgery that we all taught is coming from printing a lens by the data that we get from either a tomographer or an aberrometer, something which we have to change because aberrometers are still short because of crossover effects, and we know this very well. They lost a lot of information in a small pupil, and again, the polynomial grading interdependence that again makes a big fault with the aberrometers, and the aberrometers are not so fantastic. Now it is time for the technology to change, a major change, which is the ray tracing principle in customizing our refractive surgery. We know by fact that the ray tracers are much better aberrometers in tracing the rays to the fovea. Nevertheless, no technology up till now had able to do a ray tracing guided ablation. You have to take into consideration that ray tracer, just a few minutes and I will finish, takes into consideration the epithelial lens, which really does a big thing or a chromatic effect in the irregular cornea. Again, it takes into the consideration the posterior surface, which is mitigating the anterior surface that changes. So if you take the summation of all of them, this will make the ideal shape. And this is the new thing that we're targeting. The ideal shape is to create an ideal shape that is totally fully customized regarding the optical zone and even the connecting zone to retilt the cornea and to customize properly the ablation profile. Like exactly the genius of Michelangelo, who imagined the ideal shape out of a block of marble, we imagine the ideal shape out of the irregular cornea, and we do our surface ablation tailored to the ideal pupil. And these things, the ideal pupil, can of course, make a kind of ablation profile very small. And this is a total change or a paradigm shift in our thinking. You can do an optical zone of 2 or 3 millimeter because we have learned from the Stills-Crovert effect that the most important 2 or 3 millimeter, the most important zone for our vision is the 2 or 3 millimeter that reflects 80% of the vision. These all are taken by two intelligent machines. The Precision, which is a high resolution tomographer that will convert into the ray tracing into a true ablation profile, and the P-metric, which will calculate the ideal pupil for the technology. Even that, all things go to the cloud, and you can do your surgery remotely. And a couple of months ago, I did or performed the first patient from India, and the patient was sitting on the table in Italy, which is again will have its future application. Our dear friend Cosimo Mazzotta published the first ray tracing guided ablation, a transepithelial one for treating the keratoconus with marvelous results, and the future is now. I invite you all to these three important meetings which will take place, taking place in the WKC, which is the World Keratoconus Congress in Athens, the Lenticule and the DDEUS, which will be in India next year. And this is just a nice picture for a limestone for a man who died 2,500 years ago in Egypt, and the transliteration on his tomb limestone that he was Ni'an Khidwaw. Maybe he was the first ophthalmologist. He was the ophthalmologist of the king like 4,500 years ago. And I thank you very much again for listening.
Thank you very much, Dr. Mohamad, for bringing in new thoughts for refractive surgery.